Okay, so while people filter in, what I'm going to talk about in the first part of this lecture is the second half of what I did last time. The young woman I showed you, I had diagnosed her with PANS, and she also had symptoms of POTS, postural orthostatic tachycardia syndrome. Sent her to a specialist. She was seeing him. She walked out of the appointment. She goes, "Mom, now I have POTS and PANS?" So when I put these together, that's usually the title of my lecture, but because I couldn't do them together, so are we up here? I've got it up on the screen. Great. So now we're cleaning the pots. And the first half of this lecture will all be dedicated to POTS, and then the second half, I'm going to do 3 different case studies because I learn from cases, and I think they're a wonderful way to sort of show examples of what we're doing. So there's a little bit of POTS in 2 of them and not so much in another, but I thought they were very illustrative talks. So again, just the overview. Greater than 50% of children with PANS or PANDAS will have POTS. So even at the initial, unless you're getting them right at the very start, do think about POTS, because any autoimmune disease, especially a chronic autoimmune disease, may have dysautonomia associated with it. And I think in the toxic world we live in, with the mitochondrial dysfunction that we all may have, dysautonomia is much, much more common than it was in the past. So again, Emerson tells me, don't go where the path may lead, go instead where there is no path. These are the basic principles. It goes for POTS as well as PANS. Make sure that you've got the correct diagnosis, and then the 3 tiers: treating the symptoms, treating the infection, treating the inflammation, supporting the immune system, and separately treating the dysautonomia, and then continuing to reevaluate the effectiveness of your treatment. So some POTS. It's a dysregulation, as you all know, of the autonomic or automatic nervous system. So we think of it as abnormal control of heart rate or blood pressure, but any autonomic nervous system part, or as I say to my patients, anything you should do automatically can be affected. So you can have maldigestion, you can have sweating when you shouldn't be, you can have abdominal symptoms of other sorts, you can have muscle contractions. Anything that you should be able to do automatically can be affected by this problem. So the orthostatic intolerance is the thing we see most often. One of the things we see a lot with the children I see, because I still unfortunately have a very long waiting list, and so children have been dealing with problems for a while, so all of them come in with brain fog and fatigue. So especially looking at ways to treat that. And then one of the things that is in the medical literature that we use quite frequently is B12. Now, we will start with methylcobalamin, and we will start when we're first meeting the child with subcutaneous injections, because we're bypassing the gut. We know if it's helpful or not. It can often, in our children with autism, as you know, be helpful with language, but in our children with POTS and PANS, it can be very helpful with brain fog. It also really helps with adrenal function. This is I call this my silence of the lambs. Ooh, that's my back button, sorry. My silence of the lambs sort of pictorial of what we do to diagnose POTS. That's the tilt table testing. Don't do it, but sometimes we will send children for it. The thing to keep in mind is there are no true norms in children. Okay, in adolescence, there's a 40 beat per minute change in heart rate. In adults, it's 30 beats per minute to make the diagnosis, but there are no standards in the pediatric population. The other test we will do sometimes in our office is a squirt test, which is a sweat test, but very, very rarely. More often, I just have them do a Valsalva maneuver. I have them blow into a balloon and see if that brings on the symptoms that they're describing to me. And again, your N of 1, it's your clinical history. Again, less than one hand can tell you the number of people that have had these tests. We'll do this one, but really you'll know it by clinical history. So you all know this based on the lunch we just had, and we've had every time we're here. Unfortunately, in many of our medical conferences in the States, what we got today would be unheard of, and we'll get much more of this. This is what we all have to avoid, but certainly our children with POTS have to avoid. And any processed foods, and often caffeine, as well as non-organic produce, will worsen the symptoms. So you all know all of this. None of that is a surprise. So what else do we consider? The three pillars are increasing fluid intake, at least an ounce per kilo per day. So 30 mLs per kilo per day, which is not that much, but you'd be surprised how many children are not getting that. And it really needs to be good fluid intake. It can be coconut water, it can be water, but in the States, not Gatorade. But we do need to increase salt intake. Good iodized sea salt, Himalayan sea salt is very good. Again, these kids are having a lot of dysautonomic symptoms, pooling of blood flow when they stand up, and they need adequate salt levels, probably about a teaspoon per day, but good salt. Osteopathic manipulation is key for these children. Good physio. We have craniosacral therapists, osteopaths, aquatic therapy. It really gets things moving for them, but also can be very helpful, whether your chiro is working on an atlas orthogonal type of apparatus or any type of physio is very, very important for these kids. Sometimes compression socks, they actually have very good looking ones now, but for the kids with abdominal symptoms, the abdominal binders can be very helpful in decreasing, sort of like a cummerbund, in decreasing their abdominal symptoms. So that's something we often do also. Adequate sleep is key, and as I said, 85% will have sleep problems. And getting these kids to sleep, as one of the lecturers said this morning, at least 3 milligrams of melatonin is often needed, but sometimes much more. We also use a lot of valerian, amantilla, babuna, and almost never any medicinal sleep aids. But that is very important. Exercise according to their ability. The exercises that are recommended by David Boris, who's one of the leading experts at the Children's Hospital of Philadelphia, is isotonic exercises. And that's something they can do all the time, whether it's Kegels and squeezing their butt cheeks or whether it's just squeezing their hands, whatever they can do within their limitation of fatigue and the other things that are going on in their lives. And then, as I always say, eat food, the B12, and iron and other minerals. Many of these children are iron deficient, so look for it. If they also have abdominal problems and have constipation, I do not recommend giving supplemental iron, but giving lactoferrin. Lactoferrin can increase the absorption of iron. Also, when you're having iron-containing foods, perhaps considering more vitamin C and citrus-containing foods. But be very careful in supplementing iron in these children with slow gut function and constipation. And then the other minerals, as we all know, zinc, magnesium. Magnesium is a wonderful one for these kids with tics and OCD and anxiety, and also for those with constipation. Magnesium citrate when they're constipated, magnesium glycinate or threonate, particularly with the brain fog, can be very, very helpful. And then the zinc picolinate, but if you're getting to too high levels of zinc picolinate, you may want to consider zinc glycinate, in my opinion. And then antioxidants and glutathione support. So those are the things that we do with all the kids that have POTS and really supporting them. The medical treatments, except for a couple here, we really don't do. One of them is sorry. Let's go back. Oh, I went too far. Okay. So the fludrocortisone, we don't use. That's a mineralocorticosteroid. that can be helpful in very severe cases, but also a tremendous amount of side effects, as does midridine, which is an adrenergic agonist for more vascular support, but a tremendous amount of side effects. We will treat the gastroparesis, the gastric motility. Occasionally we'll use Xifaxan or rifaximin. But what is also reported in the literature, back to something I said in the last lecture, is Saccharomyces boulardii is very good for SIBO and for slow gastric emptying. We will use quite a bit of IV saline. If they're not getting enough fluids in, we will use it either weekly or in some children daily if they have a port. And that can be very, very helpful if you can't get enough fluids into them. Propranolol is one of the medications we will use. There's been a lot of research in POTS. It also helps to decrease anxiety. And we will use quite high doses of it as it is helpful. Start with 10 to 20 milligrams and up to 80 milligrams in some of these children in divided dosages. You have to be careful, though, if they have low blood pressures, it can lower the blood pressure even more, so it needs to be monitored. We don't use stimulant medications, although in the POTS and PANS literature, the one medication that is sometimes used is Strattera, and it has anti-inflammatory properties as well as it is used for ADHD. As I said, osteopathic manipulation, physiotherapy, and finding a good practitioner to work with. So at school, again, in addition to all the reasons they have an increase in going to the bathroom, these kids may have real poor stooling and need to be encouraged to go to the bathroom more often. They have a big change in their energy levels. It can be hyperactivity, rarely. More often, again, it's exhaustion and fatigue. And then the loss of executive function with POTS also, particularly the memory and decision making. And fainting, pallor, sweating, certainly. I have one young man in my practice that soaks through sheets and the pad underneath every single night. The physio has been the most helpful to him, but it's a very big problem. So those are the things we use. Let me show you now in some case studies exactly what we look at, putting it all together. So Drew first presented at age 9. He had a family history of autoimmune disease. Remember, more than 64% of kids with PANS will have autoimmune disease. Allergies, asthma, thyroiditis. Make sure you ask about rheumatic fever, because there is a family history of rheumatic fever in these children, and he had several grandparents, and in fact, Dad, who had rheumatic fever. The timeline, as Liz talked about earlier, is very important, and going back through that timeline, he had no antecedents. He was very healthy, except severe constipation, to the point where he was on Miralax and had encopresis. He was a sensitive kid, but otherwise neurotypical. And then Mom said everything changed on May 12th. And at that time, he started tapping his fingers to his thumbs, tapping his feet on the floor repeatedly, and he felt he had to do it. And that's something to ask the children. They feel that they can't not do it. He became more frequently frustrated, had meltdowns, always in the bathroom, said he had to urinate. It was a struggle to get him out of bed and go to school. He was very, very anxious. They discussed it with the school. He was unable to focus. Initially, they thought it was due to stress because it was state exam testing time. And Mom was concerned that it was due to the Miralax. So she took him off that and switched him to magnesium citrate at the time. So again, we have the diagnostic criteria. We've talked about this. This is him. He's got the urinary symptoms. He also had sleep symptoms, a deterioration in school performance, a regression, sensory abnormalities, anxiety, and then certainly the dramatic onset of the OCD. So Dad was hospitalized with pneumonia, with rash and joint swelling. He had a positive strep culture, high strep titers, as well as high inflammatory markers. The doctor recommended the children were tested for strep. He was tested and was positive, even though he was entirely asymptomatic, was put on Ceftonir, and everything stopped. But mom thought it was because she had taken him off the Miralax and put him on the magnesium instead. She didn't see the correlation at the time. So then on August 25th, this same year, they went away. He had an overnight change in his behavior. They were on vacation. He started having regressive behaviors, severe anxiety, fears of the darks, clinging to mom, extreme sensitivities to textures, ritualistic behavior, only drinking out of a certain cup, became very picky in his eating habits, and then started a choreiform head rocking behavior and movements, putting his chin to his chest, and then his head back, and had to do it 3 times every time. They went into a walk-in clinic, and the doctor there knew about PANS and PANDAS and put him on an antibiotic based on exam, which was remarkable, and probably the only kid in my practice it ever happened to, but thankfully he did. So he came to our office, and this was about 6 weeks later. He had a very picky diet still at that time, continued constipation. He still had continued handwriting deterioration, irritability, the choreiform movement, so that's a pictorial of what I showed you before, those piano-playing fingers, when you put your feet together, eyes shut, hands and fingers outstretched. He had white spots on his nails, so what's that? Zinc. Hypotonia, so I'm going to be looking at his mitochondria, and otherwise normal. So his titers were normal, as happens often. His thyroid function, his iron, his vitamin A, his Lyme, which being in Connecticut we get on just about everybody, but again, another clinical diagnosis we'll talk about next time. All his immune markers were normal, his urine organic acids. These were the things that were abnormal. So his ANA was positive, and as I said, this is a very typical pattern to have an elevation in that regard. His vitamin D, of course, was very low, as are 80% of the children in our practice. His zinc was low normal, and this at the time was only a plasma zinc. If you can, always get an RBC zinc. And if you get a plasma zinc, low normal is too low. Even normal is probably too low. You want your zinc levels to be high normal in any of these children that have autoimmune disease or chronic illness. His strep titers were entirely normal, and of course, as predicted, his magnesium was very low, and this was an RBC magnesium. What did we do? This is just what you know, the findings on the nails of the zinc, and the findings that we see on clinical exam. One thing to point out on magnesium that you may not know, kids with low magnesium may also have salt craving and sighing behaviors. Particularly our kids with tics or OCD that are repeatedly sighing, those are often children that are deficient in magnesium. And we use, of course, Epsom salt baths all the time. So what did we do? We had him on azithromycin prophylaxis at first, remembering to get the EKG to rule out a prolonged QT interval. We put him on a relatively high dose of probiotic as well as Saccharomyces boulardii, vitamin D, zinc carnosine, which is a very good form of zinc for the gut, but also added zinc picolinate, magnesium citrate, and this is a healthy gummy that the mom made. So I gave you the link there in case you have patients who are having trouble getting things in, and calcium, magnesium, or something that are often hard taste-wise and volume-wise to get into these kids. So she shared her gummy. CoQ10, which is a wonderful anti-inflammatory, and as Lila was talking about this morning, very good for the mitochondria. I will say that we're very, very particular about brands, and because not all brands are created equal. And I'm not going to mention any from the podium, but happy to talk about it in the Q&A part. Essential fatty acids, as I say, we often do very high doses of essential fatty acids, an excellent anti-inflammatory, but also good for the constipation. Curcumin, therapy, exercise, mindfulness, and starting the weekend of October 11th, which was a few weeks after we had started seeing him, He was less irritable, more social, no tics or OCD. He went to a birthday party and acted normally. So subsequent flares. When do we see these flares? Often we'll see them when, as I said, a sibling has an issue or when they lose teeth. And he lost a bunch of teeth all at once and had a large flare. Now, often the things we use for other microbes, viruses, strep, mycoplasma, will not work, but in these cases, it's really time to push the anti-inflammatories. And I also talked to the moms about anything that worked when they were teething as babies. So whether they used belladonna, they used a little vodka on the gums, whatever it was, just a little, I reuse it. Regression and flare, again, in the family. With viral illnesses, I will often use lysine, which is an amino acid that's very good for viruses. Vitamin A, there's been good research on vitamin A and encephalitis. We will often use good doses all the time and high doses with flares. There are good enzymes for viruses. Olive leaf extract is excellent for viruses, so those are all things that we would use. After his third flare, and again, these are flares that are very hard to prevent, a viral illness and losing teeth, he developed POTS, and he developed brain fog, dizziness, agitation. Mom wanted to do weekly bleach baths to keep everybody clean. We eventually talked her out of that. We have used it for severe eczema, but we don't want to disturb the good microbiome. We added diphenhydramine also with flares, and then really needed, with the dizziness and the agitation, really needed to add some IV fluids and IV magnesium because he wasn't able to get enough in. So we did that over the short term and then returned to the oral. And then we used helminth therapy. Liz has talked about it. You have someone among you that is training with SID to bring them to Australia, because although this particular company is very, very good, they are in the UK. And these are live organisms. They are eggs. And so the longer it takes to get into your patient, the less likely it is going to be effective. This was his handwriting even after all that treatment. And this was his handwriting after one dose. So before, after. So. In Drew's own words, before treatment, he felt shaky. He couldn't help himself but go to the bathroom. He had imaginary friends, was always talking to himself. Nothing wrong with imaginary friends. Mine was named Noonie. Very clumsy, afraid, angry, and then afterwards, calmer, felt more like himself. He can play in the gym again, and really doing well. Since I wrote this, he's had a subsequent flare, and we don't know what it was, but that was a kid that I had to give a steroid bolus, and then that got him back, and now we're back on track. I just saw him the week before we came. So, okay, Caleb is another young man. He was a 5-year-old that came in with new onset of tics, sudden onset of saying, "Excuse me." Saying it in different ways, different intonations. He would say it all the time, even in short periods where he would wake at night. Motor tics, itching and smelling his buttocks, touching his shoulders in sequence. He had a big change in his personality, anxiety, began putting everything in his mouth, frequent urination. So a classic case, right? Yeah, I thought so. Anyway. Normal pregnancy and birth, vaginal delivery, so very important. He's got good microbiome to start with. Breastfed. He was initially a poor latcher. What does that make you think of? Mitochondrial is what I think of. Did somebody say something else? Tongue tie, yes, but tongue tie can be associated with that, and it's certainly associated with an MTHFR defect, any midline defects. So absolutely. He was very healthy with few infections, normal milestones prior to the tics. He had some sensitivities, not bad. He had been on an alternative vaccination schedule by the mom's own design, had an organic diet, no known exposures, no surgeries, injuries, no previous labs, so pretty doggone good, right? couldn't get much better than this kid. And there was a family history of autoimmune disease, cancer among them, and diabetes also. So a couple of things in the recent history. He had had a sore throat at the end of March. When he's coming again is in May, but his strep culture was negative. He had had an MMR vaccine, his first at age 5, at the end of April. 1.5 weeks later, he had developed violent vomiting and a fever for a couple of days. His sibling had a positive strep throat in early May. And the symptom onset, as I said, was in early May. And then we always ask about ticks, but they're everywhere in Connecticut, so I don't believe them when they say they haven't had an exposure. I always feel better when they've had one. Don't know why. Anyway, and no other infectious symptoms. So what's the diagnosis? It's a PANS lecture, so that could be one that you say. But what else? I mean, it could be seizures, right? Could be an atypical presentation. So we've got the PANDAS, PITANS, PANS, of course. A new onset of ASD. I have had children to be diagnosed at age 5 or 6. And what his neurologist diagnosed him with was Tourette's. And it is not Tourette's. Again, Tourette's has to be of 6 months duration before you can diagnose it. And Tourette's is not of an abrupt and dramatic onset. So just wanted to say that. I was hoping somebody might say that, but anyway. So he was seen by his pediatrician, who happened to be somebody in my old group. And he was placed on azithromycin, which is often what is done if somebody does something. And there was no change in his tics. He did do blood work, and it was all entirely normal. And he basically said, see, PANDAS doesn't exist, go away. It's Tourette's. So they came to our office about 6 weeks later. We immediately started him on probiotics and essential fatty acids. I always like to say we have no protocol, but if there's anything that's part of our protocol, it is that. These children need to be on probiotics. He was already on good fermented foods and need to be on essential fatty acids. Because of my experience with children with tardive dyskinesias and tics and OCD after Abilify or Risperidone, and improving with IV glutathione after 1 dose. Often when I'm doing blood at the initial visit, I will give them a dose of IV glutathione as a diagnostic as well as therapeutic trial. So we did that at the time of blood work. We repeated some of the other tests, thinking maybe the antibody rise had happened by that time. We also did mitochondrial markers, which had not been done. We did inflammatory markers, which had not been done, vitamin A, vitamin D, MMA, which is the marker for B12. Remember, when your MMA is high, that means your B12 is low within the cell. And we did a cysteine level, which is a good marker for glutathione, remembering that N-acetylcysteine is the molecule right before glutathione and one of the precursors to it. So cysteine was the only thing that was low in this child. Normal, as you can see, is between 0.46 and 1.2. We like to see it at 1 or higher, and his was 0.36. All of the rest of the tests were normal. So he returned 2 weeks later, and his tics had completely resolved and not come back. Now, this is not going to last in most children. It's something with that level of cysteine, you need to promote glutathione production. So that's exactly what we did. Some broccoli seed extract, some N-acetylcysteine, some glycine, some B12 and folinic acid or methylfolate, and continued the probiotics and essential fatty acids. At this point in time, all he's on is probiotics, essential fatty acids, and broccoli seed extract, plus his diet, and he's been fine. So my point in showing that one is to say, you're getting all this history. This was a kid who was pretty clean, really a healthy kid prior to this time. And I think he had several insults all at once that led his otherwise depleted methylation to be more depleted. So even if it presents like PANDAS, if it looks like a zebra, it probably, if you hear hoofbeats, it's probably a horse and not a zebra, but this isn't necessarily a zebra. This is something you should also be looking at. So that's why I wanted to present this guy. And just, all of this, so I'm not going to go into it, but we need to detoxify. And glutathione is one of our best ways to do it. And many of us have genetic defects, not necessarily MTHFR, as Liz said. They may be COMT or CBS defects. And we need those things that promote the folation, methylation, and sulfation pathways. Glutathione itself is not well absorbed orally or transdermally. So as I said, we often use the precursors, N-acetylcysteine, methylfolate, methyl B12, sometimes betaine, certainly zinc, magnesium, etc. So keep that in mind. In any child you're treating, in my opinion, this needs to be looked at and those things may need to be treated because glutathione is the body's key antioxidant and really essential for everything we're trying to deflect. Okay, now Kristen. Kristen is a 14-year-old who came to me with chronic headaches. She was pleasant, there with mom and dad. She was a twin C-section, so already behind the 8 ball with the microbiome. She had had normal development, had a very functional family. Her first presentation was with PANS at age 10. Severe OCD. She was maintained on NAC, mindfulness, and exercise. And hers was a virally mediated one, but she had been put on multiple antibiotics without any protection of her microbiome. So it also developed a tremendous yeast overgrowth, thrush, vaginal yeast infections, and had subsequently been treated by one of my colleagues with a rotation of herbs. Remember, rotating the herbs can also be very important as well as rotating the probiotics. And that had been well controlled. Definitely a family history of autoimmune disease there. Her paternal grandparents had several autoimmune diseases, and she presented at this point with headaches, palpitation, lightheadedness, nausea, periodic abdominal pain, fatigue, and also had a rash that turned out to be a yeast rash. So she still, despite everything, had evidence of yeast. So here, what I'm getting at is all the POTS type symptoms. Okay, so we tested her. She had abnormal control of her heart rate and blood pressure, abnormal control of her digestive processes, the family history of autoimmune disease, and the symptoms. As I told you, she had all of these. So her history and physical exam, it's clinical history, as I said. So we reproduced the symptoms with a Valsalva maneuver. She did have in-office table testing because Dad wasn't really believing this thing called POTS and dysautonomia. He thought she was just nuts. So we proved that this was going on for her. Her baseline sitting was 110/70 with a heart rate of 72, and upon standing 90/60 and a heart rate of 115. So that's pretty classic for a POTS type presentation. So we immediately put her on B12, 75 micrograms per kilo, and often we'll do it daily initially for these kids. She had immediate improvements in fatigue and brain fog as well as her nausea. We increased her fluid intake, recommended avoiding the standing, increased her salt intake, and initially she was one of the ones that needed the IV saline. We were only giving her a liter once a week, but it was a nice boost and helped her with her brain fog and fatigue. She got a lovely little binder and some compression socks, got started on some isometric, isotonic exercises, got her on melatonin for some adequate sleep, and then got her off all the processed foods. So again, that's a typical dysautonomia type treatment profile that we will use in the kids. Other things that we will often use is licorice. Licorice root can be very helpful in raising blood pressure and decreasing inflammation Be careful, it can deplete potassium, so you want to make sure they're getting adequate amounts of potassium. This particular child wasn't on much magnesium. Magnesium can also be very helpful for headaches. You'll hear more about that with migraines with Liz. As I said, we put her on melatonin and also good sleep hygiene. Remember, a lot of these children are going to sleep in bright rooms or going to sleep with electronics, going to sleep in an apartment building. So earthing them, getting a dark room, getting all electronics, including electronic alarm clocks and cell phones, iPads, etc., out of the room, and getting some grounding material to ground them at night can also be helpful. For the pain and nausea, again, I'm a big believer in osteopathic or some form of manipulative therapy, and that was very helpful for her. And then we also did a good amount of mitochondrial support in her that was also very helpful. So these are the medications. We didn't do any of these in her. One of the ones I didn't mention before that I will mention is some of the kids with very severe nausea will do well with a quarter of a scopolamine patch. That can be very helpful for the nausea and can also be helpful for the sweating. Not in all of them, and we'll talk next about some of the other reasons for sweating besides the dysautonomia. But that can be another one that's helpful. And then looking for and treating SIBO can be very helpful in these kids with slow gastric emptying, constipation, and nausea. Xifaxan we will sometimes do. We tried that in her with no change, and again went back to Saccharomyces boulardii. And we do use that quite readily in our patients, and often at much higher doses than you would ever expect. The paper that Vicki, Dr. Mumper, and Dr. Baker wrote was on 30 capsules a day. There's now a powder that is much more concentrated, very pure, that can get a much higher dose in with less volume. So this is Kristen and my dog Fred. Again, dog therapy, very important. He's well taken care of while I'm here, by the way. So water, salt, dietary changes, the B12, the NAC, the probiotic and Saccharomyces boulardii, the licorice, the magnesium, CoQ10, the melatonin, and she's doing very well. So I had left time in this one for questions. Do you want to do any now, or should we move on to Liz and do them later? What do you want to do? Okay. And if there are any from last time, well done, that's fine too.
Okay, just a few questions you've got there already. Dosage of lysine for viruses?
Depending on the age of the child, I would use 500 to 1,000 milligrams, sort of less than 7, 500, over 7, 1,000.
Can you use Hellman's therapy while they're already on IVIG?
That's an excellent question. Although I didn't plan a Hellman talk, I should mention the caveats where you don't want to use Hellman therapy. So this is a grain beetle worm egg, and the HDCs are Hymenalepis diminutus cysticercoids, and it's a live organism, so it can hatch. The half-life is about 2 weeks, so as long as you're stooling regularly, you should poop them out before they hatch. So if you have a child with constipation or slow gastric emptying, you have to treat that first. If you have a child on immunosuppressive medications, you don't want to use Hellman therapy. And in my practice, in general, I don't use it if the child is also on IVIG, because that can, although it's supportive of their immune system, can also suppress their immune system. So I will not usually use it then. If they're seeing me before the IVIG, I will usually use the Hellman therapy first, the IVIG later. And then the two other caveats, and this was because I had the first of any of Dr. Parker's. Dr. William Parker is the person that did a lot of this research at Duke. I had the first of any of his clients with an infestation. And it was a young man who had slow gastric emptying. The parents had increased the dose well beyond what I was comfortable with and had been put on an immunosuppressant medication by their doctor. But he was also nonverbal and had a history of abdominal symptoms. So you have to be very careful with that when you're using this intervention just to protect. Now, if a child has an infestation, 1 day of Biltricide, it's treated, they're better. But it's kind of yucky. The parents don't like to see the worms coming out of the stool in something you told them to give that they already thought was yucky. So it doesn't help the ick factor. But in adolescents and adults, that will not happen. It's only in children that you run the risk of an infestation, and the rate is about 0.1%. So that was a longer answer, but I thought I should give that.
Fantastic. Dose of IV glutathione.
It depends on the age of the child. I will start usually with 1 milligram per kilogram, but anywhere up to 2,000 milligrams. In a young child, Caleb's age, I used initially 1,000 milligrams. So that's typical.
Okay, any other questions?
Do you use LD and low dose now?
Do I use LDN? It's an excellent question. I'm one of the few practitioners who has had more sleep problems with it than others. So yes, I use it. Low dose naltrexone is an excellent anti-inflammatory. There's a lot of research in MS. It can be given orally or transdermally, so it can be very helpful, but the one thing you want to watch for is the sleep problems.
Threefold question. You mentioned acetylcysteine. Obviously, it's used IV in paracetamol overdose. I use it a lot in Lyme chronic fatigue.
Yeah.
Do you use it IV?
Yes. Do I use N-acetylcysteine IV? Yes.
Second part of the question is, I've heard from some people they're concerned that it can promote yeast overgrowth in the gut orally, acetylcysteine, and is that a concern in your practice? And if so, how do you deal with that?
Is N-acetylcysteine a concern with yeast? Yes. If I'm concerned that they already have yeast overgrowth or dysbiosis, I usually do not start it. I get that under control first and then use it. I think the blister pack pills that are available in the States and that you can get here have even more sugar and more problems than N-acetylcysteine in a capsule form, but either way it can promote yeast.
And third question is, you had one of your slides, Mestinon, and I know that the Vanderbilt people have done quite a bit on that, and I've had some success in chronic fatigue. I'm just interested in if you use that at all and periodistic maintenance. So.
Yeah, Mestinon was the question, and I've used it very rarely, but it can be very helpful, and I think I have to add it to my armamentarium more in my practice because I agree with chronic fatigue, it's excellent. So. CBD and POTS, absolutely, but CBD flows out of my practice like water, so yeah. I mentioned it in the first lecture, so I tried to mention things that I hadn't lectured before. I have. Mainly because there's the POTS that I'm seeing are mainly autoimmune kids, so I think it's decreasing the inflammation, but absolutely.
One final thing as well, just, sorry, obviously vasculitis can be part of this, as you mentioned before, and capillary perfusion and those sorts of things. I know in autism, VIP is used a little bit in that context, and also things like Trental for Raynaud's. I'm just interested.
Yeah, those are wonderful suggestions. Yeah, Trental and VIP. We've had some success, but less than I would have expected based on the pathophysiology.
I'm just wondering if you're using amantadine with your cancer.
I wasn't talking too much about medications, but amantadine is by far one of my favorites. Tanya Murphy has done a lot of research on it in the States. Amantadine is an excellent antiviral and anti-inflammatory. It also is used in people with Parkinson's disease, and so we see a large decrease in OCD. So rather than any other antiviral medications, we will use amantadine first and foremost. We've had 2 children with almost psychotic episodes afterwards. When we've gone back and looked at their dopamine levels were actually quite high. So I don't have a problem as long as I tell the parents, think about this. If it happens, just stop the medication. But otherwise, we've had no negatives. Really helps their demeanor also. I find that they're much less anxious and sad. So 100 milligrams per kilogram and 100 milligrams per day, and very rarely up to 200 milligrams.
I was just wondering if you knew whether that boy, I think it was Drew, had Tylenol or Panadol after his vaccine.
Unfortunately, pretty much, at least 90% of the patients that I get at an older age have. And as you know, it decreases it was asked about Panadol, Tylenol, acetaminophen. It decreases glutathione by at least 21%. So, he had, the second child, Caleb, never had. But, okay.
Would you use Candesol when you're taking NAC?
Yes, Candesol is another one I learned from you, Frank. But we do use a lot of anti-yeast modalities, and Candesol is one that we use quite frequently. So
Let's thank Nancy. Thank you very much.